All right, so welcome everyone to the San Diego Pain Summit. I'm so excited to see so many of you here. How many first-timers do we have? How many perfect attendees from all the pain summits are here? Joletta. Sandy! I think I'm also in that camp. There's not much that would keep me away from this event. Okay, so in case you don't know who I am Sarah Haig, and I have the honor of being the Mistress of Ceremonies. I love to stay on time, and so I might be the person also getting you back in here from breaks. So please have fun on the breaks, but also let's get back in here so our speakers can share their knowledge. A couple of announcements so we can keep on time. Bathrooms across the way in the same building as the lobby. Keep that pink ticket that's attached to your bag. That's for a prize. Unless you don't want a prize, then you can give it to a friend. The COVID test kits are for your own leisure and confidence, okay? So you don't need to take one to come in every day. Just it's there for your peace of mind. They were generously donated by Jerry Durham of the Client Experience. Okay, the bubbles are for playtime during the break, not for bubble baths. Okay? Or drinking. I mean, but it sounds like they're safe to drink if that's your thing. But I'm not saying to drink them, play with them. Okay, and there's a logo wall outside. If you'd like to share a video review of your experience, feel free to stop by and have a short video taken. So you don't have to take your own video. There's a volunteer back there to assist. And I'm really sorry to announce that Rachel Zoffness will not be able to join us at the Pain Summit. She's not feeling very well, so please just keep her in your thoughts, but then also sign in and out tomorrow. Otherwise, they will not give you your credits. Okay, does anyone have any questions for me? Okay, awesome. Then I will get right to it and introduce Dr. Kathleen Sluka. She is a professor in the Department of Physical Therapy and Rehabilitation Science at the University of Iowa. She received her physical therapy degree from Georgia State University and a PhD in anatomy from the University of Texas Medical Branch Galveston. After a postdoctoral fellowship with Dr. William D. Willis, she joined the faculty at the University of Iowa. Dr. Sluka's research focuses on the neurobiology of musculoskeletal pain, as well as the mechanisms and effectiveness of non-pharmacological pain treatments. She's published over 200 peer-reviewed manuscripts, numerous book chapters, and a textbook on pain mechanisms and management for the physical therapist, which I can say is even great for non-physical therapists. And she is actively involved in the International Association for the Study of Pain and the American Physical Therapy Association, serving on committees, task forces, and society boards. So please welcome Dr. Kathleen Sluka.
All right. Well, thank you very much, and I'm really pleased to be here. This is my first time at the San Diego Pain Summit, and I'm excited to share with you, if I can get this to open. There it is. We're going to talk today about the science of exercise. Let's see. Let me get to the first slide. So we're going to talk today about the science of exercise. I don't like to stand still very long, so I'm going to move around a lot. So we're going to talk about basic science mechanisms, then we're going to talk about some clinical science, and then we're going to talk about what that means to you in the clinic and how we can improve and what this means in terms of, do you really need to understand it all? Let's see if this will work. Nope. That doesn't want to work. All right, so before I start, I want to just tell you that the work over the years on the subject is a team effort. We have an amazing team of scientists that have come and gone over the years in my laboratory, and a lot of what I'm going to be telling you about is research that has been done by a large group of individuals. It's also been funded by the National Institutes of Health, which allows us to do all these experiments. The goals today are to review the mechanisms of activity-induced analgesia, and by default, we have to talk about activity-induced pain. And those clinical implications, and we'll review the literature for the clinical implications, and then discuss barriers and facilitators to help improve implementation. We have known about the value of exercise for over 100 years. This is probably the first paper, or it's said to be the first paper published on physical therapy ever, and this was in 1921, so over 100 years ago. And what you can see is that physical therapy showed a 25% decrease in disability and saved the hospital $4,000 a year, which is a ton of money 100 years ago. And so we know that exercise reduces disability and it's cost effective. We know from studies like the Hunt study, and the Hunt study is a population-based study out of Norway, and they showed that the people who had the most recreational activity, the highest levels of physical activity, showed a decreased risk for development of chronic pain. And there are numerous randomized, controlled clinical trials that show that exercise is effective for almost every pain condition out there. So we know it works. We also know that most of the clinical practice guidelines suggest exercise should be our first-line treatment. Physical therapists are the ideal people to employ that. Not everybody with chronic pain comes to physical therapy, so physicians need to be able to introduce that also to their patients. Despite this, anyone who's ever treated a person with chronic pain with an exercise program hears that exercise hurts and I don't want to do it. And so there's this concept of activity-induced pain with an exercise task. And so one of our team members, Dana Daly, decided to ask how much does that activity increase pain. And so she took people with fibromyalgia, compared them to healthy controls, and had them move these little squares from the bottom to the top and back down again. It takes about 10, 15 minutes, and it's an upper extremity fatiguing task. And then she asked how much did their pain change. Well, in people with fibromyalgia, they got a 3-point increase in pain. That means their pain went from a moderate level of pain, somewhere around a 5, to a severe level of pain, right? Around an 8, with a simple fatiguing exercise task. So your patients aren't making this up. It really does hurt, and this is a problem. And so to understand how exercise could induce pain, and what were the underlying mechanisms, why was that happening, we had to develop an animal model to test those mechanisms. So we used this model that we developed in the lab, where we give a couple of low-intensity insults into the muscle, and we give these into the gastrocnemius muscle. So that's the pH5 there. On their own, the pH5 doesn't do anything. No pain behaviors. And then we combine that with an exercise task, where we have the animals either run for an acute period of time in a running wheel, 30 minutes, an hour, 2 hours, or we electrically stimulate the gastrocnemius muscle to simulate exercise and produce fatigue. And then we measure pain behaviors in those animals. And we do that by squeezing the muscle with a pair of tweezers. And we look for the withdrawal threshold. And this is what the data would look like. So you can see the green and the blue bars up there. Those are those two conditions without on their own. You can see that the withdrawal threshold stays at the top. It stays the same. But when we combine the two, there's a decrease in withdrawal threshold, which means the animals are now experiencing pain. And so we use that as our outcome for a pain measure in our animals. Oh, something happened to the title there. I don't know what happened to that one. Some of these slides didn't transfer quite right, but we also wanted to develop an animal model of exercise-induced analgesia. So all the experiments done at the basic science level are done in sedentary animals. They kind of sit in a cage with their friends and hang out, but they don't really do anything, right? The cage is small, so they're like most of our patients. So we gave running wheels to one set of animals, and the other animals didn't have running wheels, so we're comparing sedentary animals to active animals. And then we induce our model. And when we induce our model in the animals that with running wheels, you can see hyperalgesia or the pain behaviors don't occur. So these are our two models we're going to use to now examine the mechanisms. And I'm going to try and convince you that exercise on its own is a multimodal treatment. It works across multiple mechanisms, multiple systems to reduce pain. So early studies, and you guys know this, suggested that exercise used opioids. That's called the runner's high. People talk about release of beta endorphin. And indeed, in the early studies, if you took healthy controls and exercised them at high intensity, they got increases in beta endorphin. We also know in those studies that exercise produced analgesia. And that analgesia, which is shown in blue here with exercise, could be blocked by blocking opioid receptors. And that's shown here in red, and they blocked them with naloxone. So our opioid pathways actually are in the central nervous system. This is where most of the opioids are producing their analgesic effects. And it involves activation of the periaqueductal gray in the midbrain, sends information through the medulla in what we call the rostroventral medial medulla, or the RVM, to the spinal cord. And all of these use opioids to produce their analgesia. So, yet we didn't actually know that this was happening in exercise. So a group out of Arizona went in and said, if I exercise animals, do we change the opioids in those areas? And indeed, there's increases in beta endorphin in the periaqueductal gray, increases in metenkephalin, another opioid, in the RVM. So we're getting increases in opioids in the central nervous system, our endogenous opioids. And then a graduate student in my lab went in and said, okay, but is that mediating the analgesia produced by exercise? So we can do cool things in the animals where we can inject small amounts of a drug directly into these nuclei and block those receptors. So we blocked opioid receptors in the periaqueductal gray or in the RVM, and when we did that, the analgesia doesn't occur. So that just suggests that exercise is indeed using our endogenous opioids and activating our central inhibitory mechanisms to reduce pain. Okay, so exercise also uses serotonin. And serotonin is also found in the same area, the rostroventral medial medulla, and increases in serotonin are analgesic. Many of your patients may be on dual reuptake inhibitors, and they work to block this serotonin transporter and a noradrenaline transporter to increase availability of serotonin. So under normal conditions, serotonin is released from its presynaptic terminal, goes across its synapse, binds its receptor, and produces analgesia. We propose that in pain conditions, there's more of these serotonin transporters, so we get more of them there. If there's more of them there, that takes away the serotonin, and we then get pain because it's no longer there to produce the analgesia. So we tested that in our animal models with a technique where we can just stain for this serotonin transporter. We use an antibody, we stain for it, put a fluorescent tag on it, and you get this lovely red signal. And this red signal is all for the serotonin transporter. So this is a normal animal. This is after injury. I think you can see that there's a lot more there. And exercise knocks that back down. So if there was more serotonin transporter, there should be less serotonin, and indeed, we see less serotonin. And exercise brings that back. And the last experiment we really did to show that serotonin was involved in this process is we can use this chemical here where we can remove serotonin from the body. And so we removed serotonin from our animals and then had them exercise. And the animals who didn't have serotonin had more pain behaviors here in red compared to no pain behaviors here in blue. So that's suggesting that exercise is also using serotonin in our central nervous system to produce analgesia. What about central excitability? We talk about that a lot. What does exercise do to that? Well, one of our main neurotransmitters in the central nervous system is glutamate. And glutamate binds a receptor called the NMDA receptor. The NMDA receptor, when it's activated, lets signal in, depolarizes the cell, and does a lot of different things. Well, that receptor can become modified, and it becomes modified by doing something that we call phosphorylation. You put this phosphorus group on it, and suddenly more of that receptor will be sent to the synapse, and more current will go through that synapse. And so that if glutamate is released, it's activating more receptors and sending more depolarization to the cell. So we use this as a measure of excitability. And so again, we went in and just stained for the phosphorylated receptor as a measure of activity. And these are neurons right here in the rostroventral medulla in the RVM, where we've already talked about. This is under normal conditions. All these little red dots are our neurons. After injury, you can see a lot more of them. So, of course, we counted them. I say we, that was my graduate student, counted them. And he saw a nice increase in the number of cells in sedentary animals after injury. And when the animals were exercised, that increase doesn't occur. So exercise is also reducing our central excitability. All right, we're going to stay here now for a minute. In this same nucleus, this RVM, there's two types of cells. There's cells called on cells, and when they're activated, they turn on pain. There's cells called off cells. When they're activated, they turn off pain. So it's pretty easy to remember them. The on cells have an opioid receptor on them, the mu-opioid receptor. So that when opioids are released, they can reduce activity of that on cell and turn off pain. So we did this neat little experiment where we, again, went in there and we stained for a mu-opioid receptor, which is here, all those little green cells. We, again, used our activity marker, the PNR1, phosphorylated NMDA receptor. Then we stuck a tracer right in the spinal cord, and you stick this fluorescent tag in there, it goes back up to the cells, so you know that whatever I'm counting here is from here to the spinal cord, those cells that are turning on pain. And then we put them all together and we count them. And so we counted them, and this took years to do. It was a really big project. And it came down to one graph. And in this graph, what we found was that the cells, the on cells, going to the spinal cord, there were less of them after the exercise, which means we have less cells projecting to the spinal cord to turn on pain with an exercise task. And so we're actually changing connectivity between those places up in the brainstem that are modulating pain and the spinal cord with just an exercise task. So the nervous system is really moldable, and exercise is capable of doing that molding and bringing it back so that there's less pain in our patient just by changing all these factors. So these central mechanisms have been confirmed in human studies. In human studies, we measure central excitability with temporal summation, which is an increased response to repeated noxious stimuli, and exercise knocks that back down. The amount of exercise in individuals, the amount of analgesia to exercise correlates with the amount of central inhibition they have. And, that went too fast. Sorry about that. It's touchy. And there's modulation of cortical activity in areas that modulate pain in the insular and the cingulate cortex with exercise. So all of these things are not peculiar to animals. These are things that are happening in the people as well. So another known mechanism that we know about pain is activation of glial cells. And we know glial cells throughout our central nervous system can become activated in response to a painful stimuli. And there's two types. There's these microglia and these astrocytes. And both of them become activated. And this is just, again, one of those stains that we did to look at glial cells. And this is normal condition, and you can see there's more of it here and here after an injury. And this is a measure of glial cell activation. These glial cells release substances that then sensitize our dorsal horn neurons and our central nociceptive neurons, all of our neurons in the central nervous system. They release inflammatory cytokines. And in general, there's increases in inflammatory cytokines with injury. They can also release anti-inflammatory cytokines. And anti-inflammatory cytokines actually turn down the nociceptive signals and make them the neurons less excitable. And so after injury, there's less anti-inflammatory cytokines. So we're just flipping a balance, right? We have more excitation with injury in our immune system and less inhibition. And now you're going to get the picture because now we're exercised our animals, and you can see the glial cell activation doesn't occur. There's less inflammatory cytokines and more anti-inflammatory cytokines. So exercise is altering our central immune system as well. All right, so now we're going to switch gears. We're all done with the central nervous system. Lots of changes there. Now we're going to look at the peripheral nervous system. So in the peripheral nervous system, throughout our body, we have cells that sit within our tissues. They police the microenvironment, and they're there to maintain homeostasis. And our macrophages are a major player in this. In the muscle, our macrophages can be activated by things like fatigue metabolites, which you know about, lactate, decreases in pH, ATP, all released when we exercise. They activate receptors on those macrophages, and those macrophages can then release inflammatory cytokines, again, like our IL-1 beta, activate a receptor on our nociceptor to enhance the signal and send in signals to the central nervous system and produce pain. So we tested this, and I'll show you 3 experiments that tested this. The first one we did is we went in and we just took out the macrophages in the muscle. And we do this by injecting this drug called clodronate, and it kills off the macrophages. And in those animals, they didn't get pain. They had no pain behaviors. We then went in and said, what about those receptors on our macrophages? So we took out the ATP receptor, a P2X4 receptor, and we used this acute technique where we put in a microRNA into a virus, we inject it in there, and that microRNA just knocks down the gene. And so when we knock down the gene for P2X4 just in a macrophage, the pain doesn't occur. And then the last one I'll show you is we then just blocked IL-1 beta's effects. So we just put in a drug, we block IL-1 beta, and that effect doesn't occur. So this pathway that I just told you about, we were able to show is playing a role in that acute activity-induced pain. Now we're going to move to what happens when I regularly exercise. So we have this dichotomy between an acute bout of exercise where it's turning on things and now a regular exercise program which changes the system. So macrophages come in 2 flavors. I told you about these that release inflammatory cytokines. These are called M1s. But macrophages, like your nervous system, are really, really moldable, and they can change their phenotype. And they can change from an M1 to an M2. And an M2 releases anti-inflammatory cytokines, and when it binds a nociceptor, it reduces that activity and results in analgesia. So after injury, and we've done this in numerous different models, we see an increase in M1s, and a decrease in M2s, suggesting that at the muscle level or the site of injury, we have a more inflammatory state and less anti-inflammatory state. Exercise stops that from happening and produces more M2s, less M1s. Okay? And then we just went in and we, again, block IL-10 receptors. And when we block IL-10's effects, that analgesia that normally occurs here in blue does not occur, as you see in red, showing that this part of the pathway is involved in regular exercise-induced analgesia. All right. I want to show you this, and this is a really complicated study, so I'm just going to really simplify it for you. But we've been picking at these things one at a time. What we really wanted to do was to figure out what was going on as a whole. So we took the muscle out of the animals in exercised animals and in sedentary animals after injury. And we did this technique called RNA sequencing. And RNA sequencing allows us to look at all the genes in that tissue. There's a lot of genes, right? So you do this big statistical analysis. And so we did that, and when we did the big statistical analysis, we found a number of things that changed in both the males and the females. And we did this by sex, because there's differences between sexes. In the males and females, we had a lot of common shared pathways. There was only 159, which is your number up here. In the males, we only had one unique pathway. They were pretty much using all the same ones. In the females, we had 502 changes in genes. And when we put it all together into a formula, you can look at the pathways, and essentially what we saw was all immune. There were all changes in the immune system after pain. But there was one pathway that showed up only in females. So we find this female-specific pathway for induction of pain. And this is called an antigen processing pathway, but it's an immune pathway where macrophages talk to T cells. They're communicating to each other. And so we've gone out now, and we've shown that this pathway is indeed involved only in females. We've looked at a whole bunch of different things. I'm not going to show you all that, but indeed that pathway is a female-specific pathway. And with exercise, all of those changes and all of these different pathways we've seen, all of that is muted and gone back down. So exercise is doing a lot of things, but it's really modulating the peripheral immune system quite nicely. The immune mechanisms have begun to be looked at in human studies, and they're way behind from the animal studies, of course, but that's the way it usually is. We then translate them in. But this work by Ortega and Bote and their colleagues, as well as Erica, who's here, have shown that there's increases in inflammatory cytokines throughout the, in the blood in people with fibromyalgia. And then if they are put on a regular exercise program, those increases go back down. All right. So this is the last basic science study I'm going to tell you about. This is brand new. We just published this paper, and this, again, is everything I've told you so far is about these animals doing aerobic exercise. And so we do a lot of resistance training, too, and strengthening exercises. So I had a graduate student who really wanted to know whether or not resistance training did anything. So he built this ladder. He had the animals climb this ladder with weights on them. And he based their amount of weight on a 1 rep maximum, how much they could climb there. And then he did a progressive overload, increasing their weights by 5% per week for 8 weeks. And then he induced our model. And in the animals that did resistance training, they didn't develop any pain behaviors. Well, he was an exercise science kind of guy, and he knew that resistance training increases testosterone. So he said, Well, is this being mediated by testosterone? And so he blocked testosterone receptors in both males and females. And when he blocked those receptors, that analgesia didn't occur in both males and females. So both of them are using testosterone to produce analgesia with resistance training. What we don't know, because this is brand new, is all those other mechanisms are probably also still occurring. But there's also changes in our hormone levels. So exercise improves psychological health. You're pretty familiar with this. We know it's good for anxiety. We know it's good for depression. Work by Steve and George showed that it could reduce pain catastrophizing, which I'm showing you here, and this was a resistance training program. It can reduce fear avoidance behaviors. So we know that. We also know it can improve social health. It improves self-efficacy, improves socialization, improves concentration. It changes learning and memory, improves learning and memory. So we know that as well. We usually design exercises to improve motor function. But I just put this slide up here to tell you that the motor system and its interaction with pain is super complicated. And it's not as simple as there's always a decrease, always an increase, there's always this, there's always that. There may be multiple methods we have to use in pain to modify the movement system. And one of the things exercise does is it may improve function as well. But how it does that may be different than what you normally think. So I hope I have convinced you that exercise is a multimodal treatment. Works in the central nervous system using multiple pathways. It increases inhibition, decreases excitation. It changes the immune system in the central nervous system, in the peripheral nervous system, and systemically. Again, regular exercise does this to dampen pro-inflammatory cytokines and excitability and enhance inhibitory cytokines and enhance inhibition. And then it works across all these other systems as well, from psychological and social and motor systems. Despite this, and we know that exercise is effective for chronic pain, what exercise is most effective? Everybody has their method that they like to use in the clinic and that have compared, which could never figure out what that was from the paper. They did cervical joint mobilization exercises, kind of motor control exercises, no differences. Strength training works, aerobic works. Almost all types of exercise that have been tested work. Graded exercise works equally well to graded exposure exercise. So this Cochrane review, I still use this because I love the quote. It says, given that, in this case, motor control exercises is not superior to other forms of exercise, the choice of exercise for chronic pain should depend on patient or therapist preferences, therapist training, costs, and safety. And to me, I think the number one most important bullet point here is its patient preferences. And the reason I say that is because if they don't do it, it doesn't work, right? So if you tell me to go swim, it's never going to happen. There's nothing like swimming in negative 20-degree weather, getting outside, and your hair turns to icicles. All right? It's not going to happen. I hate the whole ritual of it. But I'll go sit in my treadmill in my basement in negative 20-degree weathers and exercise. So you have to figure out what works, right? And so this study, that still we haven't published yet, shows that the people who adhered to the exercise program had better pain reduction, lower disability, less fear avoidance, and greater strength. Not surprising to any of us sitting in this room, but surprising enough that I have to say it. So coming back here again, here's a whole bunch of quotes from patients who gave you an excuse for why they didn't exercise. You've heard every one of these from your patients. And I'm not going to read them all, but the reality is there's a lot of excuses and a lot of reasons. But we can address these. We can address these through a number of additional things we can do with our patient. And I'm just going to talk about 2 of those. One of the greatest ways to address this is with education. And education isn't us talking to our patient and telling them what's what. Education is more of a self-management and a learning environment. If you think about how you learn best not just by sitting here, me telling you everything you want to know, and you have to go back and learn it, and you have to go back and reread it. You have to work at it, and so do your patients. And it needs to be personalized. And these are kind of the things we need to talk about. We not only need to talk about how was pain processed, all that stuff I just gave you about how exercise changes all that, we should be throwing that in there so that they know that I can change my system. I gave a talk one time to public, and afterwards one of the patients came up and said, but all my changes were in the central nervous system, and I never knew I could actually change that. I thought they were wired. They were there. And I thought nobody had told her that that's changeable and that's moldable. That's a simple message to tell somebody. And then they can move forward. So if you combine education, and this is a systematic review, with exercise and compare it to exercise alone, the systematic review, and this is a very recent one, shows a significant reduction in pain above exercise alone. So simple method to put in. But what type of exercise education is most effective? Well, this recent study by Ruth Clementi, also at the University of Iowa, looked at pain neuroscience education, and we developed this pain neuroscience education in collaboration with Lorimer Mosley, make sure we were doing everything right, against a pathoanatomic educational program for people with Achilles tendinopathy, kind of the standard that everybody always used. And they both got exercise. But you can see she had the same effects on pain, function, and psychological behaviors between the 2. So maybe it doesn't matter. Maybe it's the attention they got by being educated and worked with to learn something about their condition. Mark Jensen, a psychologist quite prominent from Washington, looked at pain neuroscience education against cognitive behavioral therapy and hypnosis-based cognitive behavioral therapy and hypnosis-based pain reduction. And he showed no differences between the groups when he did a big analysis. He had moderate effect sizes, and they lasted for 12 months in people with chronic pain. So again, it didn't matter what he did as long as he did something. He showed a small statistically significant difference between these 2 groups that is not clinically relevant. All right, so we can educate in just about anything, and we probably need to think about how we do that best. So the other thing we've kind of talked a lot about was this activity-induced pain, which is a major barrier for people with pain. And if you do look at qualitative studies, that's what people say. I don't do it because it hurts. And so just think about that. If every time you're doing a task and your pain goes from a 5 to an 8, up 3 points, why do you want to do it? I mean, it's really hard to get motivated, right? So is there anything we can do to do that? Well, we did a rather large randomized controlled trial with 100 patients per group that received active TENS, placebo TENS, or no TENS at all in individuals with fibromyalgia. We gave them mixed frequency TENS to the back at a strong but comfortable intensity. We had patients use it at home for a month, and we said what happens to their pain and their fatigue. And after a month of home use, they got a nearly 2-point decrease in movement-evoked pain measured either during a 6-minute walk test or a 5-time sit-to-stand test. They got similar decreases in fatigue. And we're now doing this great pragmatic clinical trial where we're trying to test this in a real-world setting. Holly Wilkinson, who's sitting back here, is one of our sites. So we've gone out to local physical therapy clinics and asked them to help us to see if this works when we do it when we don't screen out all the comorbidities and we use it in a setting with physical therapists on a day-to-day basis. So we're now testing that to see if that works. All right, we talk a lot about barriers. We're now going to talk a little bit about facilitators, because not only are there these barriers, but what can we do to facilitate this? And there's just a ton of research out here on a lot of this stuff. This doesn't go here. There were other references there. Sorry about that. But there's a few things you can do, and this all goes into your education program. And all of these things have research to support them. We're talking about things like aligning that exercise program with the patient goals, letting them see how to do that. Employing a shared decision-making model, let them have a choice. You want to walk? Do you want to do strengthening exercise? You want to go to the gym? You want to do it at home? You know, have them work through that instead of us saying, well, this is my exercise program for you. Supervision matters. And so, I mean, this just happened to me. I went down to visit my dad. He's 90 years old. He was given some exercises, and he wasn't doing them. And I said, well, why aren't you doing them? He says, I don't know. They told me I had to have somebody watch me. I'm like, okay, well, let's do them together. So for 3 days, we did them every day. By the time he was done, he's doing those exercises every day. He's added weights to his exercises. He's going nuts, but he wasn't comfortable until he'd done them several times with somebody watching him to make sure he did them right. And oftentimes we give people home programs, say go home and do that, and we don't come back and check them. We don't ask, are you doing them? Let's do your home exercises today. Let's see how you're doing with those. We don't check them, we just assume they're doing them. We don't make sure they're doing them right or that they're comfortable doing them. So supervision matters. Make sure the program length and the time commitment is reasonable. We give patients exercise programs to do daily. How many people in this room actually exercise on a daily basis? Right, nobody. There's always one. There's always one, Jason. Okay, but look, nobody else raised their hand. Okay, 2. We got 2. But I have a person who's never exercised for 90 years, 50 years, a day in their life, and you're saying do it every day? Let's think of that. Let's do something reasonable. Is every other day going to do it? How do we work it into your schedule? Let's figure out how to do that. You can integrate it into daily activities, get them a buddy, get them in a group program, find a friend, a spouse, someone who will do it with them. And so based on all these principles, as part of another study we did to try and implement exercise and TENS into primary care practice, given that only 20% of people are referred to physical therapy, the other 80% still need this stuff, we made a tip sheet for patients. And we worked with some psychologists, Lance McCracken and Lorimer chimed in, and a few other people on campus to develop this tip sheet for patients on how to get started. And this is actually free. It's on the UIHC website. This is the link, but you can just Google UIHC and exercise, and it pops right up. But this is a worksheet that patients can go through to kind of put together how they're going to get that program started. It's a planning phase before they even get started. And it helps them to work through ways that they can address the barriers themselves and they can address the facilitators themselves. We also, over here, I put a link here. We made a little YouTube video about how chronic pain, it's like 3 minutes long, the mechanisms of chronic pain and how exercise reduces it. And it includes central mechanisms, includes the immune system, all the stuff I just told you. I have it in a 2-3 minute video for patients that's really easy to watch. It's got some cute animation in there. Okay, so there's ways we can do this. So there's ways to implement it. So let's go through the quick summary on this side. Type of exercise doesn't matter. What matters is adherence. Education can help with adherence, and it enhances the efficacy of exercise. TENS can reduce movement and evoke pain, and we hope that will help with adherence, particularly in the beginning of an exercise program. We need to address those facilitators and barriers if we're really going to get people to do it routinely. And remember, 25% of the population is physically active. The other 75% are not. Those are your patients, right? The great majority of them are your patients. And then individual supervision and shared decision-making are key to success. So I have two major conclusions. Given that exercise is safe, effective, and works on multiple pain mechanisms, exercise should be our primary choice of treatment for individuals with pain. Everything else we do should facilitate participation in increasing activity or exercise. And when I say the big term exercise, that could be just walking, increasing activity levels in some manner. And clinicians should focus on treatment of activity-induced pain to help improve adherence. It is a real problem, and it is significant for people with pain. So where do we go for the future of research? Of course, I'm going to tell you we need to understand the mechanisms, and we need to understand how broad-based they are. I think that gives us a different viewpoint on what we do. Our resistance training program we did in mice built strength in the upper extremities and reduced pain in the lower limbs. So a lot of what we're seeing are systemic effects. It doesn't matter, right? You don't necessarily have to exercise the injured area. So we need to understand these mechanisms. They'll help us guide treatments. We need and test methods to improve adherence. And we need to figure out which ones are working. We don't know which ones are working. We know some of this. What hasn't been done for most of the exercise and the way in which we apply it. Overworking this, or will we get improved results? And the last thing I really think we need to look at is what are the predictors of a treatment response to exercise? Not everybody responds with a reduction in pain or an improvement in disability. And that's true of every treatment out there. We've done that for TENS. We know what the predictors of TENS effects are. It's actually responding to a single treatment is the most predictive response of how they're going to respond in a month. Those who had a 10% reduction in pain with one treatment, likely to have a clinically meaningful reduction in pain 1 month later. That's a simple test. Are there things we could do here for exercise that would be similar? Can we begin to tailor our treatments based on that? Okay, I'm 11 seconds over. These are my take-home points. Exercise is multimodal. Exercise should be a treatment and the main treatment for chronic pain. We should add adjunct treatments to facilitate exercise and activity participation. And the best type of exercise for your patient is the one that they will do. So I do think we have time for questions now. And thank you very much. Are you here to moderate?
This year, you can ask your own questions out loud. In the past, we've had an app. So there is a microphone in the middle if anyone is interested in asking any questions. Yes. And as she's approaching, also everyone online, please feel free to put your questions, I believe, in the chat, and we will get those read aloud as well.
Hi, Kathleen. My name is Megan Doyle. I'm an occupational therapist by trade. So one, lovely talk. Love all the science. So kind of a couple thoughts and just questions. One, because you speak about the patient-centeredness and, what would your thoughts be on similar mechanisms within the context of that person's just general, functional, daily physical activity, finding things they love and enjoy to do, so more occupation-based? And then also, have you gotten a chance to take a look at the occupational therapy literature out there? Because there's really great stuff out there talking about patient-centered, not just exercise, but these occupation-based approaches. And again, just that success of being able to engage in that occupation and reduce pain from doing that.
Yeah, I totally agree. I mean, I think most of the literature out there is not actually done in physical therapy. But the literature is there and really does support a patient-centered approach. We don't know about applying it to particularly an exercise program yet. And the literature also suggests from an exercise standpoint that integrating it into your daily activities is just as good as doing a standard, I have to do my exercises today at 30 minutes, right? As long as you can walk. And if that means I park farther away and walk the stairs and to get into work every day, or take a 10-minute walk or a 5-minute walk, it's about maintaining activity as much as it is about doing a standard one. Some people need to do the 30 minutes, and some people can just work it into their schedule. So I think that's what the literature is saying. There's also a whole body of literature that I didn't talk about on reducing sedentary time, right? So just getting up and doing on an hourly basis, which is almost impossible for me to do. You know, I can't sit down and write a book chapter or a paper if I have to get up every 30 minutes and go do something. I can't concentrate on that. So I don't do that very well, but other people do. And so decreasing sedentary behavior is equally important to increasing active behavior, which is really interesting and kind of two parallel things. So just setting in your 30 minutes of exercise once a day, if you just sit the whole rest of the day, may not be as beneficial as spreading it out. So there's a whole body of literature and a whole lot of that stuff that still needs to be really systematically done in large trials. A lot of the clinical studies on exercise are actually in relatively small trials, which is a problem because it leads to bias in the literature. So thank you for that comment, and you're absolutely right. There's a lot of literature out there from other disciplines than physical therapy alone, of course.
Yeah, no, and just to follow that up really quick, you know, this is where there's that role, I think, for just helping the people we work with, such as ourselves, find these like beautiful, just novel opportunities for enjoyable movement. So recommending, hey, like if you have a family, could you guys have a fun dance party and incorporate dance? Or what are some other sensory aspects that you could integrate? And so having these much more bigger, broader, you know, picture of what is physical activity, what is exercise, like just helping people find things that makes their body feel good, helps that endorphin flow, the endogenous opioids. I would just recommend, it would be awesome to see a physical therapy, occupational therapy collaboration on this, because there's so much good literature out there on occupational therapy's role on helping people integrate that movement into their daily habits, roles, routines, and rituals. So I think the future's bright for that collaboration.
Yeah, I think so. I think, you know, my teams of researchers have always been very multidisciplinary, and I think when they are, we develop a much broader perspective in our research, and I totally agree. We need some big teams to really think through the best way to test that and to implement it. So thank you very much.
Yeah, thank you. I think someone's coming up for another question.
Oh, Jason.
Oh,
No.
wait, one in front of Jason.
Thank you for that. I just greatly appreciate your talk. I'm Baram Jam, and I wanted to ask, has anybody ever studied the mindset of the patient mattering when you exercise? Because I truly believe, you know, if you're exercising because of guilt, shame, fear, anxiety, exercising for that purpose to escape something is very different than exercising voluntarily by choice. So the analogy is 10 minutes of running. If every day you run for 10 minutes because you're running away from a wolf chasing you, it's very different neurophysiological effect than if you're running voluntarily for your own pleasure. So I don't see the studies looking at that, the mindset and the intention while they're exercising. Many people exercise for shame and guilt, which I don't think is
that's
valuable.
a really, really great point, because there is this kind of, like with any literature, like a readiness to change. And we've tried to come up with ways to measure that very simply. Most of it's pretty hard, but I think it's really important. Are they ready to implement this? But a lot of people are not, or what are their expectations and how they're going to do that? Because I think that's also really critical as an adherence-based method. If we can change their mindset and change how they're thinking prior to starting it, or at least have them work on that, we may be able to have more success. I mean, he brings up a huge point, and that's all part of it, would be put into kind of an education self-management strategy to help them get ready to even do that. So we say, yes, it needs to be in there, but it might take you 2 weeks to get somebody up to speed to be able to implement it, right? You might not be able to do it right away. Or their pain levels might be so high that they have so much fear that if you don't pull the pain levels down with every treatment you can think of and bring their fear down that they're not going to cause more harm, they're never going to move forward. So I think the mindset is really huge, and each person is why this individualized approach is so critical, that we have to evaluate what those are for each one. And so I think it's huge. I think absolutely right. There are a few studies that have begun to look at that, but it is a great area to expand on.
I just think the
for
randomized
adherence.
control trials all exclude people who never even would bother coming to a study
Correct.
on exercise. They say, screw that, I'm not doing that study.
Yeah,
They
no.
excluded all those people.
Yes.
All right, thank you. We're going to have Jason come up, and then we'll have one from online.
Hey, Dr. Sluka, thank you so much. Great presentation as always. You know, I think one of the things that we're thinking about when we think about exercise and pain, and maybe the pandemic has helped us focus a little bit more about this, is I think broadly speaking the ME and chronic fatigue syndrome area, and then specifically patients who have post-exertional malaise or post-exertional symptom exacerbation. I wonder what your assessment is of that literature currently, and what your advice is for us if we are working with patients who we think have those kinds of responses to exercise. Thank you.
That is a great question, and it is a huge problem, and we have actually started some studies on post-COVID and chronic fatigue syndrome just to actually address some of the mechanisms of post-exertional malaise. I have no data on that yet because we're still collecting subjects, but we have read the literature, and we've begun to think about it, and it is a real entity. It's very much like this activity-induced pain we're getting, but what they're seeing is this post-exertional malaise in some individuals. It doesn't actually happen in all individuals. In the ones we've had, we haven't had this happen in all of them. That post-exertional malaise, which is an increase in pain and symptoms, that lasts for many days after a single bout of exercise. And so that's a real problem. The clinicians that are working on the study with me have designed an exercise progression protocol that they're going to test to try and see if we can gauge the post-exertional, the progression and the exercise based on their symptom exacerbation, so that we would have to change expectations. So there is an expectation that they are going to have this, just like our fibromyalgia patients will have this. I think it's actually very similar, just called something different in them. And what we're looking at is, is that pain, maybe it goes up by 1 or 2 points. And if the patient is willing to tolerate that increase by 1 or 2 points, we'll continue that activity. But if it goes up by more than that, we might pace them back down. And so there's a lot of education on pacing and progression in this population because they are incredibly sensitive to exercise. But the long-term literature, it's quite controversial, but the really best studies out there that have done regular exercise programs with individuals with chronic fatigue syndrome show decreases in pain and improvements in fatigue overall. The whole point, again, is dealing with that post-exertional malaise and the treatment of that. Do we give them TENS? Do we come up with some pacing mechanisms? Do we do it a much more slowly progressing increase than we would with it? And so our goal is to kind of come up with some kind of an algorithm where you could kind of work with the patient in an individualized manner so that you could get them eventually to a 20 or 30-minute exercise program. But you might start at a minute or two, right, if they're really sensitive. Some of the literature that's showing really severe post-exertional malaise was done from groups that actually see the worst of the chronic fatigue syndrome patients. And so it may be a little bit higher than what you see in your clinic, because some of you may have seen chronic fatigue syndrome in your clinic, and you may not see all of your patients out for a week after they do an exercise task, right? You may see 1 or 2 of those, but the other ones are less severe. And I think we need to get some studies that are recruiting more broadly from the general population too, to see if it's really there must be a broader spectrum of response. And so we just keep talking to clinicians to get more thoughts on how broad that is. And so the postdoc that's working on this, he's going to also look at what the immune response is to that post-exertional malaise, so we can try to begin to see if that's we think it's an enhanced inflammatory state that's happening. And if we know that, then maybe we can do something to reduce that as well. But it's a great idea, and it's a wide area that we don't know a whole lot about. There's almost no literature on this process in post-COVID. Right, and they have the same thing. I actually think post-COVID's probably the same thing. Very similar.
Amazing. We're going to take one question from online, and then I think that's all we're going to have time for. Sorry. So if you could please read the question from online.
So to clarify an earlier slide, is there less functional connectivity between the RVM and spinal cord of both on and off cells after exercise? Would this mean that opioids and GABA-acting drug effectiveness is changed by exercise? Is the question.
Let's see if I can understand the question. So you are asking again if the opioids are working by modulating the on and off cells in the RVM, and that exercise is actually modulating those cells through an opioid mechanism. And we don't know, right, directly. We would have to have actually recorded from them to know for sure. And if you can correct me if I'm wrong on that interpretation of your question, we know that there's changes in those cells. We know that there's less of them projecting to the spinal cord to modulate pain. And we also know that those areas have opioids in and use opioid receptors to reduce pain with regular exercise. The link between the two we don't know, because to really know that it was that cell, we would have to actually directly record their activity levels, and we haven't done that. That's a very hard task to do in a mouse. And we don't do that much anymore like we used to. Does that help?
There's no response yet.
What was that? I didn't understand.
I haven't heard it.
There's no response yet to that.
Okay. All right, well, if there is clarification on that later, maybe we can grab you at a break.
Just, send me an email, and I'll respond. And maybe we can have a little discussion about it.
That's a great offer. Thank you so much, Dr. Sluka, for a great talk. Everyone, now it's break time.